Good morning, one and all. A warm welcome to Swapna's Radio Info. Let us go into the interesting case which we have seen in our department. Case number one. A 25-year-old primary gravida came for the growth and well-being scan to our department at 32 weeks of gestation. Her NT and TFA were unremarkable. These are the antenatal scan images. You can see a moderate amount of collection in the peritoneal cavity with echoes. This is the red arrows, echogenic ascites. In this image, you can see the polyhydramnios AFI being 30 centimeter. This is a four-quadrant method which we have measured. Uh, Fetal MCA Doppler, you can see the peak systolic velocity being 51 centimeter per second, and it's around 1.1 MOM, ruling out the fetal anemia. So ultrasound findings, fetus was found to be around 32.4 weeks of gestation. Biophysical profile score was 8 by 8. Scan shows polyhydramnios AFI is 30 centimeter. A moderate amount of collection noted in the peritoneal cavity with thick low-level echoes, ascites with thick particulates. There is no bowel dilatation, no peritoneal calcification, no obvious cystic lesion, no other features of hydrops, fetal brain and heart being normal. Antenatal workup was done for immune and non-immune hydrops and was found to be negative. Torch infection was excluded in the torch screening profile. Diagnosis of isolated echogenic fetal ascites was made. Probably meconium peritonitis secondary to the bowel perforation, that is type 1 FMP, was given. Mother was admitted and was managed conservatively for 4 weeks. Then the baby was delivered by lower segment cesarean section. The baby did not cry immediately after birth. Apgar scores were 6 at 1 minute and 7 at 5 minutes. Neonate had tachycardia, tachypnea, and capillary refill was 4 seconds. In view of distress and antenatal diagnosis of the fetal meconium peritonitis, neonate was shifted to NICU and was nursed in the thermoneutral environment. Neonate was kept nil per mouth and was started on IV fluids. Postnatal scan on the first day showed moderate echogenic ascites. Neonate was operated on the second day of life. Intraoperatively, a perforation in the terminal ileum was noted. Meconium peritonitis with moderate ascites were found. More than 400 ml of meconium fluid was drained. Perforation site was excised and ileostomy was done. Edociolysis was also done. A thorough peritoneal wash was given. So you can see this is the picture showing the perforation in the terminal ileum with the feeding tube in situ here. These are intra-op pictures. Neonate was shifted to NICU and was managed with fluids and was on noradrenaline support. Neonate went into asystole on the third day of life and could not be revived. So coming to this case number 2, a 25-year-old primary gravida came for growth scan to a department of radiodiagnosis with 32.5 weeks of gestation. Her prior NT scan and TFA were unremarkable. So these are the antenatal scan images. You can see a moderate amount of collection in the peritoneal cavity with thick echoes. These red arrows are showing echogenic ascites. This echogenic peritoneal calcification and intrabowel calcifications you can see very clearly in this image. In this image, you can see moderate amount of genital sac collection with calcifications. So coming to the ultrasound findings, fetus was around 32 weeks, 5 days of gestation. Scan showed polyhydramnios AFI being 25 centimeter, gross ascites with particulates with peritoneal calcifications, and moderate genital sac collection with calcification was noted. Antenatal workup done for immune and non-immune hydrops and was found to be negative. Torch infection was excluded with torch screening profile. As the patient was affordable, we have sent for cystic fibrosis gene mutation and was found to be negative. So diagnosis of echogenic fetal ascites with peritoneal calcifications, moderate genital collection with calcification was made. Probably meconium peritonitis secondary to the bowel perforation type 3 we have given as diagnosis. Mother was admitted and managed conservatively for 5 weeks. Baby was delivered by lower segment cesarean section. Baby cried immediately after birth. Apgar scores were 8 at 1 minute and 9 at 5 minutes. Postnatal ultrasound was done on first day of life and showed moderate free fluid with thick echoes. in peritoneal cavity with calcifications, and genital sac collection was noted. In view of antenatal diagnosis of meconium peritonitis, baby was shifted to NICU and nursed in thermoneutral environment. Baby was kept nil per mouth and was started on IV fluids. Neonate was operated on the second day of life. Intraoperatively, a perforation in the distal ileum, 20 centimeter proximal to the ileocecal junction, was noted. Meconium peritonitis with dense adhesions were noted. Perforation site was excised and ileostomy was done. Edociolysis was also done. A thorough peritoneal wash was given. So this is an intraoperative picture showing the perforation in the terminal ileum with the feeding tube in situ. Neonate was hemodynamically stable and continued on a mechanical ventilator and shifted to NICU and extubated on the post-op day 1. Neonate was discharged in a healthy condition on the 11th day of life. Biopsy report showed distal ileum with perforation with mild inflammation and peritoneal calcification. So coming to the discussion. So fetal meconium peritonitis is a rare cause of non-human hydrops with a reported incidence of 1 in 35,000 live births. It is defined as aseptic chemical localized or generalized peritonitis caused due to intrauterine bowel perforation and extravasation of meconium. Favorable outcomes have been seen when the condition was detected in utero rather than when the neonatal diagnosis is made. Coming to the causes of meconium peritonitis, ischemia in the mesentery, volvulus, intestinal atresia, meconium plaques, internal hernia, Hirschsprung's disease, colon atresia, and cystic fibrosis. These are various etiological factors. So coming to the pathogenesis of meconium peritonitis, all the causes of bowel obstruction, it may lead to ischemia and necrosis of the bowel, leading to perforation, thereby spillage of sterile meconium into the peritoneal cavity, leading to the area of chemical peritonitis, which acts as a site for in utero calcium deposition. Hence, we can have the 3 different types of presentations, either fibroadhesive type, generalized type, or meconium pseudocyst. Coming to radiographic findings, plain radiograph, abdominal radiograph shows intra-abdominal or peritoneal calcification, mass containing calcification. If process vagina is patent, you can see the calcification within the scrotum. So in this radiograph, you can very clearly see the calcified meconium pseudocyst, and you can see the punctate calcifications in the right hypochondrium. These are peritoneal calcification. Coming to ultrasound features, antenatal scan shows either fetal ascites, polyhydramnios, dilated fetal bowel loop, meconium pseudocyst, intrabowel peritoneal calcification. In this image, you can very clearly see the dilated fetal bowel loops. In this image, you can see the intra-abdominal calcifications. And in this image, you can see a meconium pseudocyst completely occupying the left hemi-abdomen. Postnatal ultrasound shows highly echogenic, linear or clumped foci of calcification giving snowstorm appearance. These are peritoneal calcifications, these arrow marks. Coming to the types of fetal meconium peritonitis, type 1, type 2, type 3. Type 1 is associated with ascites. Type 2 is associated with pseudocyst formation. Type 3 being associated with fibrous adhesions and calcifications. So we have the grading system, Jangary's fetal meconium peritonitis grading system. Grade 0 is simple intraperitoneal calcification. In grade 1, we have the ABC. Intraperitoneal calcification with ascites is grade 1. In B, it is associated with pseudocyst. Grade C is associated with intestinal loop dilatation. In grade 2, we can see intraperitoneal calcification with above 2 kinds of ultrasound abnormalities. In grade 3, intraperitoneal calcification with more than 3 of the above related ultrasonic abnormalities. Prenatal diagnostic tests such as fetal chromosome karyotyping, gene microarrays, and TORCH screening are recommended in the case of suspected prenatal fetal meconium peritonitis. So coming to the treatment, according to the grading system proposed by Jangere et al., grade 0 fetus require no surgical intervention after birth. Approximately 50% of grade 1 fetuses will require the surgical treatment. Almost all grade 2 and grade 3 fetuses will require postnatal surgery. So these are the various references. These are the various interesting articles which we have referred. I I would like to thank our consultants, Dr. Sanjarani ma'am, Dr. Nagajyoti ma'am, Dr. Pingili Gopal sir, and Dr. Pavan sir, our pediatric surgeons. Thank you so much.